Hi, Mandy and Julie, and welcome to the GI Health Summit. Thank you so much for being here.
Thank you so much for having us, Chef AJ. We're honored to be a part of this.
Well, I love your t-shirts, Adore Your Pelvic Floor, and I know that's what we're going to be talking about today. You know, I was interviewing some doctors and they were mentioning something called pelvic floor physical therapy for certain patients with certain GI conditions. And this isn't something that I think a lot of people know about. I know I certainly didn't know about, and I really couldn't find that much information on it. Now, I know you both are physical therapists specializing in the pelvic floor. So maybe you could talk a little bit about what pelvic floor physical therapy is in general and how it might help certain people with certain GI conditions in particular.
Perfect. So yes, we specialize in pelvic floor physical therapy. When we're looking at the pelvic floor and the dysfunctions that some people may have, we're seeing, a lot of disconnect between the mind and body, how our bowel movements are happening, even linking it with the nutrition. But from our aspect, we're really looking at the muscles of the pelvic floor and how we're able to pass that stool with a bowel movement.
So where is the pelvic floor? What is the pelvic floor? Because that's a new word for a lot of people.
Absolutely. That's such a great question. So we've got a 3D model here, and a picture is worth 1,000 words, right? And you are right. No one understands that they have a pelvic floor. Women and men both have pelvic floor musculature. And we keep it really simple. We describe this as these are skeletal muscles like every other muscle in your body. They just happen to be on the inside. And they're a little bit different and unique in that they have an intimate relationship with your organs. So particularly in females and women, with the uterus, and when women and men, the bladder, and then in women and men, the rectum and the anal canal. So these muscles really have five distinct jobs. Number one, they have to fire so that they keep us continent. So they help with sphincteric control, but then they also have to relax at a moment's notice so that we can eliminate whether bowel or bladder. Number two, they work with our abdominal wall muscles and our low back muscles. So they fire with every step we take. They're part of the inner core, and everyone's heard about core work. Number three, they have a sexual functioning. So they have to, again, relax if you're female for penetration, and then they have to be strong to help with orgasm, whether male or female. Number four, they have a supportive function. So they hold up all our organs in through here. You can see right here, this is a female model. So we have the organs coming through the pelvic floor. So it would be bladder, uterus, and rectum right in through here. And then number five, they have this sump pump action. So when they contract, they help push things through this area of our body, whether the lymphatics mostly is what we're talking about here.
Well, why is there dysfunction in the first place? What would cause people to have dysfunction in the area? Medications, aging?
Yes, so that's all some things we're going to dive into today as we go through our presentation. But it can be a variety of things from medications to diet to lack of exercise, and then looking at the integrity of these muscles, any tightness or weakness in the pelvic floor.
How would you even diagnose that? Like people go to the gym, for example, and maybe take a class that's geared towards their abs or their glutes, or they see a trainer that works on specific muscles, but nobody's ever told us like, well, do something for your pelvic floor muscles. It's really a relatively new concept, at least to me.
So what we're looking at here, so we have another model here, and we like this model because it has this hole. And you can see we do a lot of internal exams in order to better assess and feel how are these muscles tight, are they weak, what does their strength look like, and that allows us to then assess and better get an idea of how the pelvic floor is working or if it's working incorrectly. So then we can help patients to retrain them and help them to normalize their bowel and bladder habits.
Right. And Chef AJ, you just made a good point. Like it seems so new, and the truth is it's not that new. So I am like double the age of Miss Mandy here. So I've been doing it for over 20 years. It's just now finally it's getting the recognition that it deserves. I mean, when I started this work way back when, no one heard of it. It was so obscure and people were like, you're doing what? So now finally it's becoming standard of care. And one of the things that we hope to see is that eventually it just will be, something that everybody knows exists and everybody is just like going, and we're not supposed to say going to the dentist because we don't want it to be that kind of experience, but like you just go check in, you have an assessment of your pelvic floor because it radically can change your quality of life. And let's be preventative instead of waiting for a problem to happen, right? And we're chasing it.
I certainly hope it doesn't become like going to the dentist, because there's nothing that, well, just because I have dentophobia and there's.
Well, and that's something too, Chef AJ, from my perspective and, kind of my age range of viewers, we just think this is supposed to happen. We're supposed to have bowel movements. It's all supposed to be normal. We don't talk about it. A lot of people, as I've, entered this world, we're finding they're telling me things and they didn't even realize what they have is abnormal for both bowel, bladder, and sexual function. And so just really raising awareness on these taboo topics and trying to let the world know we are here to support you and help you on your healing journey.
Right. I think and what I'm learning from this summit from the doctors when they talk about their patients, it's just there's shame and embarrassment when you talk about anything pretty much from the waist down.
Yes. So we want to make these quote taboo subjects not be taboo. It's just normal, right? It's anatomy.
It's funny. I know people personally, and I've heard from people that have suffered from constipation for almost their entire life. And they've taken so many laxatives that they don't even work anymore. And they've pretty much given up hopes to ever have a normal bowel movement. And then one of the doctors said, oh, well, I send these people for pelvic floor physical therapy. And I'm like, you're kidding. There's something more these people can do. This is exciting to me because I'm thinking of a friend's mother who's in her 70s now. And this could be just revolutionary for her if she could get this kind of treatment.
Yes, absolutely. Yeah. And so common in our world, we say that these issues are common, but not normal. So yeah, we got to just change the thought process. And then thank you for getting this information out to a greater population.
Yeah. Well, show me what you got.
All right. Okay, so we're going to be talking today about constipation in the pelvic floor. So I just wanted to start with some alarming statistics that a lot of people aren't aware of. So 15 to 20% of adults are going to suffer from constipation. A third of those are going to be over 60, and this is more common in females versus men. When we look at physician visits a year, 2.5 million physician visits are happening each year, and the most common complaint is for GI. So just looking at the constipation, very, very prevalent out there in our communities. And then over $750 million are spent every single year on over-the-counter laxatives. And so you kind of touched on people that, they've overused laxatives and now they're not even effective for them. And that's what we're seeing in kind of laxative abuse. And so just a few, so people kind of know what they are: Miralax, Milk and Magnesium, Dulcolax, and Senokot are just a couple. So what is constipation? We get this commonly. People don't even know what's normal or not normal. So when we look at defining constipation, we're looking at those infrequent bowel movements. It's defined as less than 3 a week. The stools are really difficult to pass. They're typically hard, they're dry, they're lumpy. The feeling that you're not getting all the stool out. And I think this picture really depicts it well. You can see all those little tiny balls of stool in there. And so thinking about trying to pass that all out at once, for most people, it's just not going to happen. And that then leads to this constipation. So what are some symptoms of constipation? If you're sitting on the toilet and you're straining a lot, that is not normal. That is a sign that your stool is hard, it's not able to properly pass. Bloating, headache is even a sign of constipation. Decreased appetite, as you have all that stool building up in there, you're just not as hungry. If you're finding you're able to pass gas easily, but you're not able to pass a bowel movement, that's a sign of constipation. And then some other ones people don't think about are bad breath and depression can both be related to constipation.
Okay, so what causes constipation? There are a lot of different things that feeds into this. We can look from a diet perspective, and it can be the type of foods we eat and not getting enough fiber, which we'll touch on in just a little bit. It can be lack of physical activity. We think about what's the first thing. For example, if you're in the hospital and you've undergone some type of surgical procedure, the next day, or even later that day, they will not discharge you until you actually have a bowel movement. And part of the problem is that, if you have been inactive and undergone anesthesia, that's going to decrease the motility through the system. So lack of physical activity, motion is lotion, is huge. Medications, we'll touch on a couple common medications where the side effect is constipation. We treat a lot of pelvic pain in our practice. And so unfortunately, with some of the narcotics that are prescribed, this is a common side effect. Dehydration and lack of appropriate water then can also further feed into constipation. We talked about laxative use. If we start looking a little bit more systemically, we can look at even deficiencies with vitamin D and even with magnesium as well. Pregnancy is another common time that we see that women struggle with constipation due to the changes in the pelvic floor, changes just in what's happening with the viscera and the positioning of that as the baby grows. Ignoring the urge to go is a big one. When we get that urge registered on the brain, and if we actually contract our pelvic floor for long periods of time to decrease that urge, that will backfire. And as you will go in and look at the anatomy, you're going to see what happens when the pelvic floor actually becomes overly hypertonic, or it gets stuck in this contracted state, and then it makes it difficult for it to elongate when we need it to eliminate. And then gut dysbiosis and issues within the gut itself can feed into constipation as well. A couple other things we want to talk about, looking from a wider lens. Sometimes the nervous system plays a role in constipation. So in patients or people that have a neurodisease process going on, such as MS, or after a stroke, or Parkinson's disease, or a spinal cord injury, whether complete or incomplete, that can certainly feed into issues with constipation, and pelvic floor PTs can absolutely help with this. We can look from an endocrine system perspective and metabolic disease perspective. So hypothyroidism is another really common underlying perpetuating factor, both for constipation and in terms of the state of musculature or skeletal muscle tends to be more hypertonic or have a state of spasm when thyroid issues are present. Diabetes is another example too of a metabolic disease. Then we can go right into the direct anatomy and look at colorectal issues. And so there can be a problem related to scar tissue, and that can be on either within the abdomen surrounding the colon itself, or lower with where the rectum is, and the anal canal, tumors, cancer, anything that creates a change, compression of the intestines. Even women who suffer with endometriosis and have, adhesion formation that starts to develop within the abdomen will absolutely influence the ability of things to move through the colon. And then lastly, a hypertonic pelvic floor. So the muscles we demonstrated for you, in those muscles, they become shortened and overactive at rest. So really then let's break down, I always keep it really simple for patients. There's two types of constipation. Let's break it down. So we can have a primary or functional, and then we can have a secondary type of constipation. So within the primary, we break it up further and we say, look, the problem can be within the gut itself, and you can have a slow transit time within the colon. Or number two, you can have a problem actually further down, and you can have an outlet obstruction. And this is truly an issue with the pelvic floor musculature. So I describe this as the train actually arrives, but it can't leave the station because the muscles are so hypertonic, and they're influencing the external anal sphincter and the ability also to be able to evacuate completely. And that's But pelvic floor really comes in beautifully there, but we can also help with the slow transit time as well, which we're going to go into in just a bit. We're going to demonstrate some basic techniques that you can use. Then secondary type of constipation could be medication induced, like we already talked about, the metabolic diseases we talked about, a neuropathy. So again, back into what's happening with the nervous system, and then a myopathy more related to the muscular system.
All right, so we kind of touched on that medications can contribute to constipation. So what I like to think about is when I go and pick up a prescription, whether it's for myself, my husband, my kids, you know, the pharmacist always says, oh, these are the side effects. Do you want me to go over them? You know, here's your little pamphlet. And most of us are in such a hurry. We're just, oh yeah, I'll take it and go. And so we forget to actually look at, well, what are the side effects of some of these medications? So, calcium channel blockers, diuretics, antihistamines, all things that are very common we're taking. Side effect can be constipation. I know Julie touched a little bit on the pain medication. So we're looking at those post-op patients for whatever, you know, thing they had in the hospital, whatever surgery they had. When they're coming home on any pain medications, constipation is a common side effect. And it's a huge reason that they end up back in the hospital after coming home due to impaction, meaning they can't physically get their stool out. Also, some supplements such as calcium and iron are linked to constipation. Antacids, medications for cholesterol, heart, Parkinson's disease are all linked to it, looking at antidepressants, and then also overactive bladder medications. So even though, you know, looking at pelvic floor issues, we treat a lot of patients with those overactive bladders, but a side effect of those medications is constipation. So we've talked about constipation, but what's normal? So again, a lot of people don't even understand what normal is. And really it varies. It can be 3 bowel movements a week. It can be 3 bowel movements a day. So what we're really concerned about is, what is your normal? Did you go from having a bowel movement every single day to now you're only having one 3 or 4 times a week? Well, that's abnormal for you. So we really want to get a baseline of what your normal is. And then again, thinking about, did I start any new medications? Could that be a contributing factor for me? Looking at the stool, it should be a solid piece. It should be shaped like an S or a C. We want that because it's going to mimic the shape of the colon and coming out all in one piece. Your stool should sink. It shouldn't float in the toilet. And then during an urge, you should only have to relax. You should never feel like you're really straining or pushing down. Again, that can cause that hypertonicity of the pelvic floor and then lead to further difficulty with defecation. It should not be painful to have a bowel movement. Some people just think, oh, well, it's just always been a little uncomfortable. I thought that was normal. It's not. And then there shouldn't be any incontinence with a bowel movement. So looking at the digestive process and how things are broken down, it starts in our mouth. So if you, for example, are eating an almond, it takes 40 full chews to fully break down an almond and then allow it to properly digest. And if you think about that, how many of us are chewing our food 40 times with every bite we take? You know, most of us are eating on the go, whether we're at our desk, we're in the car, in between meetings. You know, we live in a very fast-paced society. And so when we're thinking about food, a lot of times we're just putting it in, but we're not really taking the time to properly break it down, which then can lead to constipation issues. So the digestive breakdown is going to start in the mouth, going to go to the stomach, small intestines, the pancreas, and the liver. And it's going to break down different things in different areas. So from the starches to your proteins, your carbs, and your fats. And then just something interesting, you know, looking at the stomach, it can hold a liter of food or fluid, but we're going to feel full at half a liter. So when we first get that feeling of, oh, I'm full, but then, you know, there's this huge plate of food or there's this dessert over here we want to eat, we need to really stop and think to ourselves, do we really want to eat that extra food? Because if we're inputting more in our system than what we really need, that is going to lead to higher chance of constipation also.
Okay, so when we look specifically at the colon, you can reference the picture down there, normal transit time is anywhere from 24 to 72 hours. And the colon overall will receive anywhere from 1,000 to 1,500 milliliters of thick liquid per day, but really only 100 to 150 milliliters is reabsorbed to pass as the stool, hopefully not too hard, it's as hardened stool, to the rectum. What happens through the ascending, transverse, and descending colon is we normally get this natural peristaltic wave or waves that occur. So these are involuntary movements that like these contractions that push the matter through. And so we can definitely look at help to push form stool through the colon if this is impaired. And very shortly, we're going to show you a great technique called a colon massage on how to assist this process if it's impaired. All right, so good to understand, an important take home is that a lot of colorectal conditions absolutely affect the pelvic floor or have involvement of the pelvic floor musculature. So when we talk about the pelvic floor, we've been talking about like this high tone or pelvic floor state, right? They're too overly active at rest, but you can also have on the opposite end of the spectrum, a low tone. And so pelvic floor PT, one of the nice things is we do an assessment internally to figure out what state these muscles are in. There are signs and symptoms to tell you if you have a high tone or low tone pelvic floor, but there is nothing like confirmation and actually palpating the musculature. So then we also want to go further and ask, well, is the pelvic floor actually the cause of the constipation that we're talking about today or any other issue related to pelvic floor dysfunction? Or is it the victim? And is it trying to compensate for an issue elsewhere? Other diagnoses, really quickly, that can have a colorectal pelvic floor muscular component specifically are anismus. And this is a fancy word for involuntary spasming of the rectal pelvic floor muscles. Crohn's disease, ulcerative colitis, and irritable bowel syndrome. And each one of those diagnoses, I'm sure, Chef AJ, you can do a whole summit on any one of those. So we're just touching, basically highlighting that when people have those diagnoses, that they definitely want a pelvic floor PT as part of their healing team. All right, so here we go. We're going to dive into a colon massage. So this is something we teach routinely in our practice. We want to empower patients to be able to become the CEO of their own body, is what we always say. So this can be done to help stimulate that peristalsis motion that we were talking about to decrease constipation. And I'm telling you, this one works because I have struggled with constipation and I've done this, especially when I travel. And lo and behold, yes, you will get things to move. So typically what we want to do is we want to start on the left side, and we're going to help facilitate the peristalsis, and we're going to work, it might seem a little counterintuitive because we're going to start on the left to clear what's happening on the left lower quadrant where the sigmoid colon sits. So we have to, quote, prime the pump first. If we started on the right where the ascending colon starts and we move everything through up the transverse colon to the descending colon, but we have this nice restriction and blockage down low at the sigmoid, everything's just going to back up and you're not going to move that. So we clear first what's happening in the left lower quadrant, then we move right up to the descending colon, then we clear the transverse, which is coming right across right under the rib cage horizontally. And then lastly, we'll pick up the ascending colon and we're going to use manual techniques to move everything through the entire colon. So Mandy's going to hop on the table right now. We're going to demonstrate what this looks like. I'm going to walk you through. All right.
I just have to say, this is amazing.
Okay. All right. So we're going to go through then how we would do a colon massage. So let's trace out the colon first. So we have ascending colon that starts on the right side. So we have before we even get to the colon itself, we have all the loops of the small intestines running in through here. They transition into the large intestine, which is the colon, right over here in the right lower quadrant through, it's called the cecum. And the ascending colon will now come from right inside this ASIS, the pelvic bone here, and it runs right up to the inferior rib cage. At this point, there's a flexure, it turns and it becomes the transverse colon until we get right to the inferior left rib cage, where it then makes another turn and comes down to the descending colon. And then right inside the left lower quadrant here, the sigmoid colon sits. And this is our reservoir that holds all our stool before it empties into the rectum. So when we talked about issues with transit time, this is the component that we're talking about with the colon, that decreased peristalsis as part of an underlying reason that people suffer with constipation. I'm going to come over here to the left side, and I am going to, again, prime the pump. Now, another important thing to understand is I can historically work with my hands to move things through, but the descending and the ascending colon actually sit retroperitoneal, and what that means is they sit closer to the back than the front. So when we teach colon massage, we actually teach to use two hands instead of just moving things through the front. Historically, this is how a lot of people have been taught to do this, but this is a great hack and trick to really help make it a lot more effective. So I'm going to take my second hand right through, Mandy, if you just roll over really quick so people can see where I'm at, right in through here, okay? At the same time, I'm going to use my hand through the front, and I am going to do this circular rocking motion, and I'm gently going to clear what's happening down here by her sigmoid colon. So my hands are working in concert. Now you might think this is kind of hard if I'm doing it on myself. So one thing you could do is lay it on your side and you could work these together. If that becomes too hard, you certainly can just use your hands through the front, but this is a little bit more effective. So I'm gonna think about doing a scooping motion just like this, right? If I just slide on the surface of the skin, I'm not doing enough to help create that peristalsis. So I've got to get in here and I've got to start to move things through to facilitate. So I'm going to clear sigmoid and descending colon first. So as I do this, I'm going to do about 5 passes. And again, my scooping motion is always down in this clockwise position here. I get a little bit of rocking going too. The body loves, the colon loves movement. So think about some rocking and cross body movement in general, which is good. And after I do about 5 passes of clearing this, I'm going to come pick up now what's happening with the transverse colon. So because of the position of this, it's too hard for me to get this through the back. I am going to use both hands, and I'm going to come from the right inferior rib cage, following across the upper abdomen. Ooh, we just got a GI sound. That's good. We always love to hear the little gurgles. Until I get to the inferior rib cage on the left. Now I'll come back in and I'm going to pick up what's happening again, coming all the way back down towards the sigmoid colon. I would repeat that another 5 times. Now let's pick up the first part of the colon, the ascending colon over here. And let's do the same thing where I've got one hand behind, one hand in front. I'm doing this circular motion coming up through here to facilitate the peristalsis. I get right to the inferior angle underneath the 12th rib. I start to head over. I'm now on the transverse colon, working everything over and across till I get to the descending colon. And then I make my way down to the sigmoid colon. And if a person really has significant constipation, you will feel the stool palpable, especially down here through the left side, where it's held through the sigmoid colon. And, and the patient or the person suffering gets the buy-in because they can feel it, and then they really can work to move that down and out. Okay.
That is amazing. I had no idea such a thing even existed.
Yes. All right. We'll bring you back over here, Chef AJ.
I love how you said the train arrived, but it didn't leave the station. And that's something I'll remember that, because that's how I hear people sometimes describe their constipation. Like they know they have to poop, the poop's there, but they can't go.
You don't know what to do. How do I get it out?
Yes.
So what do they normally do though? Push, right? They strain. And that backfires, which we'll get into in just a minute. All right, so we'll bring our, all right, let me put our presentation back up here. Okay. So talking a little bit further about the pelvic floor and its relationship. So there is a muscle called the puborectalis. This is part of the levator ani muscle group, which is just part of that pelvic floor muscle. And so looking on the model here, it's this muscle here. It slings around the rectum, and you can see it in the picture here, how it connects to the front on the pubic bone, and then slings all the way around the rectum at the junction of the anal canal. And so we'll talk a little bit more about why that's important. So when we're looking at the puborectalis, and then we start talking about that anal rectal angle. So it's the angle formed between the axis of the rectum and the anal canal. So you can see it right here with my cursor. This is what it looks like in sitting versus a squatting position. So much larger in a squatting position. So the normal angle for an individual is 80 to 100 degrees. Now what happens when that angle decreases, it can lead to that straining. It can also lead to that incomplete emptying. So when we talk about those decreased angles and looking at the relationship then to constipation, it's huge. So what we want to see is we want to increase the angle. This is going to allow for a more successful bowel movement, which is what we're really looking for. And it does that by relaxing the pelvic floor and allowing for the stool to drop down versus having you to just strain and push to get it out. So you're going to get a increased angle by increasing hip flexion or squatting to get that bigger angle. And so why does this matter? The relationship between that anorectal angle and the puborectalis. So the angle is going to vary depending on the strength, the length, the coordination of that puborectalis muscle. And so that's going to have a big impact on how stool, or if we are able to pass it, or if we're going to be constipated, or vice versa if we have any fecal incontinence. So if there's weakness of that puborectalis, it's going to increase the angle, and that's when it can lead to fecal incontinence for people that have very loose stools. But then looking on the opposite, if it's really tight and spasm, it can lead to that decreased angle and lead to that outlet constipation. And that's what we see, both aspects of it, but definitely the constipation side is much greater. And so again, just looking on here on the model, you can see that muscle, how it slings around the rectum here. And so if it is tight, it is going to put a pull, decrease that angle, and lead to constipation. So we want to show you just a little demo here, just to try to make it, sometimes on models it's hard to see. So we want to give you a little demo here to show you a little bit more. Okay, so if this is our rectum, and here is our lovely puborectalis muscle. So a normal angle is between about 80 to 100 degrees, as we talked about. So that would be about normal. If we end up, it is tight, you're going to decrease that angle. So if you look here and you think about, well, how is my stool supposed to get around that sharp curve? It's not. Or you're going to have a lot of difficulty. And these are the people that are then leading to that chronic pushing, straining, which then results in more hypertonicity or a tightness of the pelvic floor. So then it just makes their problem worse and worse and worse. And so this is why if we can retrain and really treat those pelvic floor muscles to get them healthier and then teach patient better bowel habits, it's huge in helping with constipation. Okay, so this takes us right into how should we be pooping? Okay, defecation mechanics. There are actually things we can do to make this a much more successful event. So number one, how many of us have been in a public restroom and we walk in and we go, ah, that's so gross or dirty, right? That you don't want to sit on the toilet seat. So a lot of people will hover. And if we hover, we're actually activating our pelvic floor. Remember, these are skeletal muscles, and so they can contract, and we do have some voluntary control over them. So they will be active then. And if those muscles are active, just what Mandy just showed with the sock, right? You're going to have that increased angle. You're right through here, where you're not able to eliminate. So you need to just sit on the toilet. You need to do whatever you need to do to be able to get over it and sit on the toilet. And at home as well. So the next thing, even if you're sitting on the toilet, the higher your toilet is, it changes the relationship of what happens with your knees to your hips. So you really want to, first of all, make sure that your knees are at least equal to your hips, if not higher than your hips. We're trying to mimic that squat position. A squat position will change that angle and help open it up. So the chute is open and we can eliminate better. So there is something that we have in the clinic here. A ton of our patients have it at home. All of us PTs have it at home, and it's called the squatty potty. And you can see in the picture over here, it's basically like a step stool, and it changes that angle and brings your knees up higher than your hips, relaxing the puborectalis, and then changing that colorectal angle right through there. So that promotes better relaxation. Next, then, we want to think about what's happening, not just with the abdominals, but also with the diaphragm and breath work, which we're going to do another demo in just a minute. And coordinating the right breathing at this time to avoid straining or bearing down is another critical component to having a really good, successful bowel movement. So just as Mandy said, if we resort to straining and pushing and bearing down, all those increased intra-abdominal forces are going to actually activate the pelvic floor. It's a gentle stretch to your pudendal nerve, which is the main nerve that innervates these muscles, as well as a lot of the genitalia within the pelvis. And over time, too, that can lead to even something called pelvic organ prolapse, right? That gently can push and result in one of the organs descending and sometimes prolapsing through one of the openings. So important to remember, if you're not successful, you can try again later, but we're going to demonstrate right now, I believe, right? Yes. What it looks like to sit on the toilet the right way.
It's interesting that we have to actually learn this. I live in a 55 and older community, and our toilets aren't even like this. They make them higher to make it easier for the person, and it's actually making it worse for them.
Yes, it's easier to get on and off the toilet, but then harder to have a bowel movement. And I'll just tell you, Chef AJ, because I think this is funny, but I know the holidays are far away, but all those white elephant, when you can't think of a good gift to put in, I had a family member came home with her squatty potty from a white elephant. She said, "What am I going to do with that?" And I said, "Hang on to it. One, you're going to want it when you're pregnant. And two, all of us, we want to improve our mechanics." And so, of course, shortly later, she was pregnant and she said, "Oh my gosh, I don't know what I would have done without my squatty potty." And I said, "I know, I have one." And so we can't recommend them enough to help improve that angle. And so we're going to show you what that looks like here.
Because I was looking at the website and they said 7-inch or 9-inch. How do you know which is right for you? They have one that actually does both.
So yeah, depending again how tall you are. And I think how restricted the musculature is. So you could always start with, let's push this back. Start with the lower one, or if you're really tall, then get the higher step stool. Or if you have long legs like Miss Mandy. Yeah. All right. So a couple of things that you can do when you're sitting on the toilet. So say you don't have a squatty potty right now, but you know that constipation is an issue. Just even going up on your tiptoes and leaning forward a little bit is going to increase that angle and allow for a better bowel movement. But the squatty potty is nice. You just keep it right by your toilet, bends right in, and that's going to make a nice angle here. As an added bonus, if you have small children, they can use it as a little step stool to get on and off the toilet, like we do at my house. Perfect. So as you can see, then Mandy now can lean forward, and she can also think about incorporating some diaphragmatic breathing. So when we get into the parasympathetic state, that is our rest and digest state, right? that is going to help facilitate us to be able to eliminate better. It also helps in the sense that the diaphragm, which is our main breathing muscle that sits right up through here, has a pressure relationship with the pelvic floor down here. And when the diaphragm descends, the pelvic floor descends. And we want the pelvic floor to descend and open so that we can eliminate. So breath work can be very powerful during this time and can be integrated as well. Anything else?
Yeah, and then we just wanted to show you one stretch also that is going to be helpful for patients who are, to help open things up, would be a deep squat stretch such as this. It's just a nice stretch to open up the pelvic floor, get a nice stretch through the adductors. Now, if you're out there and you're saying, there is no way I could ever get in that position, don't worry, we have another way to show you. Yes. So let's move our camera.
Are you going to do happy baby?
What's that?
Are you going to do happy baby?
Shoot, Mandy.
Turn it this way a little bit. This way. So,
I'm going to pick it up.
okay.
Sorry. Okay. Oh, there we go. Kind of.
There. Okay, so you can do a happy baby, but also a modification would be just grabbing either your shins or your thighs. So for some people, this is going to be much more comfortable. They can't do a full happy baby. So we want to really tailor it to what each individual is able to do, because obviously we aren't all the same.
Right. I'm thinking of some of the older people I know, and they're going to be like, what?
Yeah, they're like, I can't get in a happy baby. So that's why.
Okay,
we'll come back over here.
Perfect.
All right.
And I'm just talking about this. I'm going to throw in one more quick story because we think we're so civilized and advanced, like in the West, with all these great toilets. But as you said, it works right against us, and think of all the cultures out there. How do they, Middle East, Asian cultures, how do they go to the bathroom?
They squat.
They squat, right? So I had a patient that was Iranian and we were working. She had constipation, but the big thing that brought her in was she had this really severe pain every time she urinated, urethral burning and irritation. So we did pelvic floor PT, which consisted of a lot of internal work to release the musculature. She left because she was a teacher for the whole summer to go back to Iran. And as she's leaving, I taught her everything she needed to know. She was really nervous. What am I going to do? There's no pelvic floor PT over there. And I said, you'll be fine. So she came back 3 months later and I'm all, Farah, how'd you do? She's like, I did great. I had 0 symptoms. I had 0 pain. I said, well, what was the biggest thing you thought that helped? She said, it was because I squatted 5 to 6 times a day to urinate, to defecate, right? That's how you do it. And she said, it's so dramatic that not only did she get a squatty potty, she actually got, it's called, it's Nature's Platform is the website, but it's this wooden platform that goes right over your whole toilet because she really wanted to truly mimic the squat. And when she first came home, she was trying to balance on the toilet. I was like, you're going to fall. You cannot do that. So I go on this website, order this. And she did. And this is how she now defecates, and she's like,
it's incredible. It's like we need to get, a lot of people want to get rid of television. It seems like we need to get rid of our toilets.
Yeah. I know.
All right. We're going to share our screen here again. Okay, so looking at defecation issues, again, that constipation. So those frequent suppressions of your bowels, we don't want to be suppressing the urge. Another interesting component is stress. So that increased sympathetic output. So that central nervous system, when we're under a lot of stress, it's going to result in deficits in digestion. It's going to lead to more constipation. And so whether it's stress at home or stress at work, it's definitely a contributing factor to constipation, something to be aware of. When we look at cramping, the volume of the stool, it's too large. The rectum is not properly able to distend and let that stool out. It can lead to that very uncomfortable abdominal cramping. And then also incontinence. So if you have a movement of stool that's too strong for the strength of the sphincter, so that internal and external sphincter muscle, that external sphincter is a voluntary control. It's going to squeeze, it's going to try to hold it in for you. But if it's too weak or it's uncoordinated, it's not going to be able to do that. And so that's where looking at pelvic floor physical therapy, we are able to identify that weakness or incoordination and be able to help patients learn how to retrain and properly use their muscles to assist in bowel movements. And then looking at dyssynergia. So the muscles of the pelvic floor, they can become uncoordinated, and this is going to make it difficult to have a bowel movement. And so looking at this picture, you can see where that puborectalis, where it slings around there, and then you have your internal and external anal sphincters. And so if they are uncoordinated in any way, this is going to lead to deficits in having a bowel movement. And so looking at that, it's going to need some neuro re-education, or we need to retrain how to properly relax and contract of the appropriate muscles of the pelvic floor and the abdominals. Because like Julie talked about, they work hand in hand together, that as the diaphragm is dropping, the pelvic floor is going to drop, and allowing that proper intra-abdominal pressure to assist with a bowel movement, let it help you versus it working against you. And so we want to show you just a short demo also on proper diaphragmatic breathing. If you can sit up here.
Okay. So Mandy is going to show you. I'm just going to use my hand so you can see what happens here. As she takes a breath in, we always want to look and see what's happening with the relationship with the upper cervical musculature right through here and the chest. So a lot of people will use all of this as their primary way to breathe. And when this happens, the diaphragm isn't doing what it's supposed to do. So this is our primary breathing muscle here. And the goal is like we said, that this needs to distend, this needs to lower, it needs to elongate right through here. And then the pelvic floor will follow. If you're using all of these accessory muscles up here as your primary strategy to breathe, diaphragm stays pulled up, pelvic floor stays pulled up too. So one thing we teach patients to do is to monitor here and here. And we want to feel that the breath, we still will get movement here. You cannot not get movement, but you need to make sure you get movement lower in the abdomen and the belly. And we think about that belly gently bulging out, but we also want to think about what happens from a three-dimensional standpoint. So I can put my hands on her rib cage and I want to feel this expansion laterally as well coming through. So we'll practice this, and this is such a critical piece, not only just for the diaphragm, but again, to get us into the rest and digest state, the parasympathetic state. And the pelvic floor musculature is governed by our autonomic nervous system, so that makes these muscles a little more unique. And Mandy was talking about the influence of stress. So stress will influence how things literally move through the colon, but it also, it completely influences how active the pelvic floor is because it is governed by that state. So we get the benefit both ways as she works on her diaphragmatic breathing. And this takes a while if patients are not used to this, and we do go through very specific training on how to do it, and we even get some expansion going through the back. And then it's part of a home program that we give patients.
Okay. It just seems like it would have been easier if it was designed like as a straight tube, and all those twists and turns, it's got to go through so many spaces just to get out.
Yes, so true. Okay. All right, looking at time. So we're going to go super fast through these last few slides.
No, take your time. Honestly, it's okay if you take a little more time.
Okay, all right, okay. So we're going to just touch on a few other issues that are related to the pelvic floor and things that we treat as pelvic floor PTs. And we want people to think outside the box when they suffer with these issues. So hemorrhoids is a big one. And really what a hemorrhoid is a varicosity in the rectum or the anus. They can exist either externally or internally. And what causes these? A lot of the things that we already talked about, that chronic straining. So whether that's going to be daily because you're straining with defecation or even urination, we'll have a lot of patients who use a quote Valsalva voiding just to urinate, and because again, they're in a rush or maybe they have some hesitancy. Increased pressure with pregnancy and birthing is a big one, especially with second stage of labor and excessive pushing. It's very common to end up with hemorrhoids, increased time on the toilet. And then just over the years, as we age, you get changes in the connective tissue. Unfortunately, that happen and occur. So that can increase hemorrhoids. We educate a lot on, again, empowering the patient and what they can do. So sitz baths are one, ice packs, working on all the things we already went over on how to basically not just craft a better stool, but how to deliver that and poop better and make the experience better. We want to improve the stool consistency and the overall habits of defecation. And then a lot of times, because of the pain associated with hemorrhoids, the pelvic floor musculature will react. Remember how we talked about, is the pelvic floor a driver or is it the victim? So when you have that kind of pain, you better believe that the musculature comes in and goes into this guarding protective state. So a lot of times when the hemorrhoid does resolve, patients come in and they're like, well, I don't have evidence of a hemorrhoid anymore, but man, I still have a ton of rectal pain. And usually that is coming from the muscular component. All right, fissures is another big thing that we'll treat too. So what a fissure is, think of it as a paper cut within the external anal sphincter. So it's a tear of the skin that occurs, and it can cause severe pain with bowel movements, and sometimes in significant cases, not just with a bowel movement, patients will have pain even with walking or sitting because of a fissure. So that can lead to what Mandy was talking about earlier, like the suppression, the urge suppression. So you're going to contract your pelvic floor because you don't want to defecate, right? And then, of course, then that leads to harder stool. Further tearing and irritation can occur because when we contract our pelvic floor, what we do is, in that shortened state, we restrict blood flow from coming into the tissue. And it's always, at the end of the day, all about blood flow. So as I make my fist here, if you can see me, my knuckles are turning white because I'm not getting blood flow. So I always describe this to patients as a really simple example of what happens with an unhealthy puborectalis or another pelvic floor muscle that does this. We need it to be able to do this to get blood flow, and we need that excursion. And a fissure needs blood flow to heal. So without addressing the muscular component, a patient's going to have a much harder time getting this to heal.
Okay, and then looking at our postpartum mamas that have undergone vaginal births, they've had third or fourth degree tears, are more likely to be affected. And so looking at that anorectal integrity, so that skin, how much did they tear? Was it into their anal sphincter? Was it their perineal muscles, or did it all go all the way to the rectum, as in a fourth degree perineal tear? For these moms, they're going to have a lot harder time postpartum with the recovery process. And so not only constipation, but they can also suffer from incontinence. So both issues are a problem for this group of people. So who's at increased risk? Which moms? Those that had instrumental delivery. So they used a forceps or other other instrument to help with the delivery. Large babies. So if you had a high birth weight, a nice healthy baby coming out. Yeah, big heads, as my kids both had. And then persistent posterior orientation of the baby. And what that means is the baby's head is faced out towards the belly, towards the mom's belly, versus in back towards the spine. So that's going to have an increased risk of a larger tear. And then just to touch on constipation in pediatrics. So this is a major problem for a lot of young kids. And so looking at those hard stools in early childhood, it's going to increase the risk of bowel issues for school-age children. Also kind of interesting is if a child undergoes a really stressful life event as they're younger, they're more likely to suffer from constipation as they're older in the school-aged years. So it's just something to really, as a parent, obviously we all want what's best for our kids. And so looking at these issues early on, early intervention is key. We want to prevent adult bowel issues from developing. And so if we're noticing this, especially in our young children that we're still helping with their bowel routine, really important to talk to their doctor about getting some help for this. And then again with kids, as we've talked about with adults, don't ignore the urge to go. Suppression will just lead to further constipation and increase issues contributing to it.
All right, we'll touch very, very, very quickly on just a couple things to think about from a dietary perspective considerations. So specifically, and again, you could do a whole different comment on this, but foods linked to constipation tend to be wheat and gluten. They're inflammatory in nature, dairy and milk, red meat, fatty fried foods, bananas, which can help if you have the opposite problem and you're suffering with diarrhea, but bananas absolutely can be constipating. Foods on the other end of the spectrum that loosen the stool, alcohol, caffeine is a stimulant. We'll get a lot of patients that come in and they're like, that's the only way I can poop. Is that when I have my coffee, I need to have my coffee every morning. So again, we want to change that. I mean, we still want them to enjoy their coffee, but we don't want them to be dependent on that technique. Spicy foods, artificial sweeteners that are in a lot of different drinks and sodas, sugar, prunes, plums, apricots, and pears. And obviously we're going to talk about water intake, and we want to make sure that patients are hydrating appropriately. Okay, and then fiber, we'll just touch on real quickly too, because we want to make sure that patients are getting appropriate type of fiber and the right amount. So this is a plant material that is resistant to breakdown in terms of, it's a complex mixture of it in terms of digestion, and its whole job is to combine with water in the colon to prevent water from becoming reabsorbed into the walls of the intestine. And I think the big take home here is an average American eats about half of the recommended amount per day of fiber that they need. So
all right, and then looking at, we talked about the importance of movement, so exercise and constipation. So the importance of movement, it's going to help reduce constipation by decreasing the time it takes the food to travel through the large intestine. And why this is important is if the food is moving through the intestine faster, there'll be decreased water absorbed. So the stool will be more of a normal consistency versus that dry, hard kind of pellets, which are difficult to pass. So we want to shoot for 15 to 30 minutes of aerobic exercise per day. Now that's going to look different for everyone. For some, it may be a brisk walk, it may be a jog, it may be the elliptical, a nice bike ride outside. Or for others, it may even be an aerobics class. So, it's not, we want to find what you enjoy, but just get out and move 15 to 30 minutes every single day. That's the important part. And then again, I know we talked a lot about this, but that suppression, do not hold, go. It can lead, when you are suppressing the urge, it will retrain the brain to know what is normal, and it will lead to constipation. So best time for bowel movement, 30 minutes after breakfast or lunch. Your body's able to use the gastrocolic reflex to help improve a bowel movement. And what that reflex is, it's a stimulation of the bowels after eating. And so you want to make it a routine. You want to eat around the same time every day to promote those normal bowel movements. So if you're finding you eat breakfast every day and then you head to the office and you're driving and you're suppressing your urge, then maybe you need to change the time you're eating breakfast, either a little earlier so you can have a bowel movement at home, or a little later so you can have a bowel movement when you get to work. So you're not having to suppress the urge every day in the car.
Okay, and lastly, we want to just wrap up with something called the Bristol stool chart. And this is a great reference for you to use as a patient, an individual suffering with constipation, or even if you're wondering, do I really suffer with constipation, on what, quote, normal bowel movements look like. So we have anything ranging from type 1 to type 7. Type 1 and type 2, these are typical experiences of constipation. This is what you will see, right? These separate hard lumps, like little nuts, hard to pass, or even like that sausage shape, it's all lumpy. That is indicative of, yeah, you're suffering with constipation. We start to move in then to type 3 and type 4, which is definitely where the zone we want to be in. So really type 4 is like, yay, that's where we want, right? So it's smooth like a sausage or a snake. It's soft. We want the C shape or the S shape, again, following the position and shape of the colon. And then towards the end of the scale, that's when we end up with the opposite problem. If we're at type 6 or 7, where now we help patients then on the other end of the spectrum, because it's more difficult then to control their stools and their bowels.
All right. And so, here at Start in Physical Therapy, we are here to help you. You do not have to, and you shouldn't suffer with constipation. There's so much we can do from a pelvic floor standpoint to help you out with this. And we would love to assist anyone who is interested or has questions regarding their individual case.
Thank you.
No, thank you. This was an amazing and comprehensive presentation. It was phenomenal. But this is an in-person treatment. I know we're doing everything on Zoom now, but you really need to be able to assess and examine the individual, right?
Yes. I mean, you can absolutely start with a lot of golden nuggets through telehealth. And we do that for people who live across the world, even who don't have access, because unfortunately, we're not there yet with pelvic floor PT being standard of care. And we don't have an army of pelvic floor PTs out there yet, but it is growing. So yeah, you can, just what we did today, hopefully can even start somebody on the right journey. But at the end of the day, we do need to feel the musculature. So finding them somebody to work with and do that exam, and then any manual treatment that is needed will take them all the way.
Just to be clear, only females do this, right? Because I can't imagine I would feel comfortable having a male do that exam on me.
Oh, so as a therapist. So at our clinic right now, we are an all-female clinic. It's just kind of how it is. But we are open to males, and there are many male physical therapists that do pelvic floor therapy. But currently at our practice, we do not have one. But as our therapists, we do treat men and women who suffer from constipation because, it doesn't, both genders have this issue. It's not something that's just female related, so yeah, we see both.
And, the men, in terms of the patients that are men, they have such a harder time finding a pelvic floor PT, unfortunately, right? Because, they're usually routed either to a urologist or a colorectal doctor. But again, I think there's almost like this, I don't know, it's like, not that it's, what do you think?
Just looking again, taboo, there's not a lot of male physical therapists that are diving into pelvic health, and we need more. So, if there's any physical therapists out there that are men, please think about joining the pelvic world because you are needed.
So you become a physical therapist first, and then you specialize in the pelvic floor.
Correct. Yeah, it's a subspecialty, just like in medicine, where you can have, have an internal medicine or generalist, and then you can specialize within neurology or management.
So now that some people are becoming aware of this treatment for the first time, can they just go straight to you, or is it better to get a diagnosis, say, from a GI doctor and then be referred? And are a lot of your referrals from GI doctors? Because that is how I heard about this.
Yeah, so we do get referrals from GI doctors, but to be honest, Chef AJ, a lot of our patients are just finding us. They're searching, they're Googling, they're on Instagram, and that's how they're finding us. And so oftentimes we're their first person that they may have talked to about this issue. Or we get on the opposite end of the spectrum. We get people that have been to a multitude of doctors, and they're coming to us kind of as a last resort. But typically those patients are not the ones that are coming. Constipation is aside. Many of our patients don't come to us because they have constipation. They come to us for other problems, and then they were like, oh yeah, well, I've had constipation for years, and then we're able to address that. But rarely do we find somebody comes, or not as often does someone come strictly for constipation, and they should, because unfortunately, with the constipation and those changes in the pelvic floor, more issues are going to arise. It's not a matter of if, it's a matter of when.
Right. That was really fascinating when you said you have to ascertain if the pelvic floor is the cause or the compensation.
Yes. A great question to ask. And that's why we love putting our detective hats on, because we get to figure that out. I mean, just the way medicine is being practiced nowadays, the physicians don't have that much time. So, I mean, it's common for them to spend maybe 15 minutes with their patients. We're with them for almost an hour. So it gives us the opportunity to dive in and really pull back the layers and figure out what's going on.
Well, the fact that we're spending $750 million a year on laxatives, I think this in the long run would be cheaper to just have a few sessions.
Absolutely. I think we're all looking for a quick fix. Like, oh, I can go to my pharmacy and I can just grab this, or, and I can take a supplement, or it's going to help me, versus looking at really doing the hard work and the commitment to pelvic floor physical therapy. And unfortunately, like we talked about, it is a taboo topic that a lot of people, we get some of our patients say, I don't tell anyone I see you, but thank you so much for everything you've done for me. But it comes back to that shame or embarrassment, because it is such a, kind of private.
Right. Well, that's one of the reasons I'm doing this summit, because I've got a newsflash. Everybody poops. So
Exactly.
Yes. And that's why we encourage our patients, go out and talk to your friends, talk to your family, because you will not believe how many other people are out there suffering, right? And they want to talk about it. So they just need you to bring it up.
You talked about don't ignore the urge to go, never suppress it. It almost sounds like suppression leads to depression, but sometimes you can't go. Like I work with people that have jobs where literally they have 2 15-minute breaks. And if they have to go, they're not allowed. It just seems like our society does not make it easy for us to go to the bathroom if we have a job working for somebody else. There's like a very specific time.
And I think the take home on that, Chef AJ, because I completely agree. Sometimes you just physically don't have access to a toilet. The take home on that is if you're in a place that you do have access to the toilet, don't suppress the urge at that point. Don't push it aside because you're, cleaning or playing with your kids, or you're on your phone, or whatever it might be. When you have the opportunity, take it. Don't suppress it if you don't have to.
Right. Because there's an old saying, when you got to go, you got to go. But if you don't go, then when you got to go, you won't be able to go.
And I think it brings up an important issue with our school system, although right now with COVID-19, where all the kids are at home, at least here in California, they are. But we need to allow our children to go to the bathroom as well, right? And not think that this is, no, you're trying to just escape from, no, you need to allow them urinate.
I remember it was really difficult even in grammar school. Like you had to get a hall pass. It's like as if you were going to leave or something. It was like a major ordeal to try to go to the bathroom if it wasn't the time. I know they don't make it easy for you to move your bowels in this country.
No, we have to intervene on all levels.
Oh, that's so funny. So how long does it take to recover with you doing this kind of physical therapy till somebody could see some results or some improvement? And I would imagine that even if they only have a certain amount of sessions with you, they'll have to continue practicing this at home. They can't just have you go for a few sessions and then forget about it.
Right. That's a great question. So typically what our response is, it depends on how long you've suffered with it, right? So we go back to, it's very different if you come in with a 20-year history versus a 6-month history. So, and then it can be anywhere, the shorter the amount of time, it can be anywhere from let's do 4 to 6 visits, good, or even 3 to 4 visits. But if you come in with a 20-year history, that's a whole different ball game that we're talking about. And it can be months. So, and all the comorbidities that surround it, what else is going on? And we tend to get a lot of really complex patients. So
do you ever treat the opposite, like people with diarrhea, because can they be helped at all? Maybe they have the opposite problem. It's the opposite. Yeah.
Yeah. So looking at, again, that puborectalis muscle. So if it's too loose, it can increase that angle to, and so people that do have more of that loose stool can have more incontinence. Also that external anal sphincter, that is a voluntary control muscle, meaning we can help train it to get stronger and to better be able to hold the stool. So we do see both ends of the spectrum. I'd say constipation is definitely more common across our society, but fecal incontinence is definitely an issue also, and something that we do treat.
Yeah, because one of the things you mentioned when you had that list, IBS was on that, and that seems so common right now.
Yes.
Yeah. Well, this has been just so enlightening. I'm fascinated by, and thank you for the work that you're doing. And hopefully people that will watch this summit will learn about this and learn that it's an option and they should try it out. So Mandy and Julie, what's the truth about GI health?
The truth, it is such an important factor, again, that can radically change your life, right? But the good news is you have control over it way more than you think. So be empowered. And like I said, our goal is to make everybody out there the CEO of their own body, right? So you just need to make the commitment and take control. And we always say we're here to help guide you. We don't want to, yes, quote, fix you. We want to empower you to take that step. So, I mean, it can just bring such quality of life from every angle and aspect if you can get this dialed in.
Yes, because unfortunately, when you suffer from constipation or the opposite, fecal incontinence, it just has such an impact on your everyday life, from being uncomfortable and pain, all those other side effects that we talked about. And so it literally affects every day. And so also, and if I'm in the parenting days, so I have young kids, thankfully they have normal bowel movements, but I have friends who talk about, my child can't poop and they're so uncomfortable, they're crying. So it's a major problem that affects literally from the youngest to the oldest out there.
Well, thank you. We got to get America pooping again.
Yeah.
The right way.
Maybe I'll get that T-shirt. Well, thank you so much, Mandy and Julie.
That's great.
Thank you so much, Chef AJ, for having us today.
You guys are great. Thank you.
Thank you.